let's talk a little bit about traditional second-line therapy. Ed, what are your factors? How do you, let's say you use, whether you use 4 or 6, and we've made the argument that there's really not a good maintenance strategy. 4 months later, the patient is progressing. When do you jump in with second-line therapy? What are the factors that you're thinking about or influence your decision-making?
Yeah, it's interesting because, as is in history, we've divided non-squam or non-small cell and small cell. So they're definitely different buckets, and we consider them a little bit differently. We've considered non-squam and squam being almost like small cell, where there hasn't been much and there's not a lot. And if a patient has squamous, you're like, oh no, that's, darn, or you're a heavy smoker. Immunotherapy has clearly changed that. I mean, I have so much optimism now when I see a person who's had, 60-pack year smoking history coming in, right?
Right. You used to sigh. And
exactly.
Yeah.
I'm like, oh man, I bet you're going to be PD-L1 positive. I mean, these are the things that you're hoping for. And so that happens now in squamous, whereas in non-squam, we didn't look at lines of therapy as much anymore because it sort of all has meshed together with the integration of maintenance and biomarkers, and is giving an EGFR drug first line the same as giving a second line then afterwards. No, it's really first line revisited. And so I think squam is trying to move in that direction right now, but we're still a little ways out. We have one marker. So it's PD-L1, and if you have our high expressor, which again, I think we hold out hope, especially in patients who have squamous histology, because they do usually have smoking histories, that those can be categorized. If not, we've discussed the cytotoxics up front. And then the second line. So we have a couple to choose from, though 3 actually right now in immunotherapies. There was some interesting docetaxel ramucirumab data before. We've had EGFR TKIs in there as well. And then the whole potpourri of chemos that never really proved themselves so much, but existed in that setting.
And were used.
And were used quite commonly.
Yeah.
Gemcitabine, navalbine, you name it, mitomycin, others that occur, and we're also in Kettering data. So, I think the paradigm is beginning to shift. I think PD-L1 has started to bring that together, as well as the immunotherapies. Now, we're not thinking about, Pemetrexed is a great drug for a non-squam. I wish we could have the equivalent for patients who have squamous cells. So it's nice to see that happening, that now lung cancer is starting to become a little more universal. I think of the breast cancer patients and not just that triple negative population per se. I do think these patients are beat up more, but if there is more immunotherapy given and monitored, I think that's going to change our approach to patients who have squamous histology.
Right.
And it will allow them to take some subsequent lines of therapy and get more therapies in. So I don't think we look at them anymore as the pessimistic, oh man, they're going to be a lot of comorbidities, a lot of problems with breathing. I think we actually look at them in a different manner now.
Yeah, no, I think I'll never forget the first time I saw the Checkmate 017 overall survival curve with a hazard ratio of 0.59 and curves that went like this. In squamous, that was the reaction there. And then, the Pembro data. But I want to get over to Jared, because a couple months ago we had the Oak data presented, and yet another choice. And I'll come back and kind of ask people what their go-to immuno is in second line. But the Oak data obviously included squamous patients, a positive trial. Your thoughts on the Oak trial?
Yeah, so once again, we saw, in this case, a PD-L1 agent beating docetaxel.
Docetaxel's had a rough couple of years.
Well, docetaxel, I don't know. It was never my most beloved drug. After cisplatin, it might be my least favorite cytotoxic that we use in the thoracic oncology space. So I was thrilled to see docetaxel get beaten up yet again. So the story was a lot like we've seen before, we've seen previously. Better outcome results, better tolerability. I think what was unique here that influences our clinical practice, actually, there might be 2 things to take away from this. One was the subgroups. Every subgroup looked better. We got some subgroups we hadn't seen before. But for the practical clinical purpose, this is an every 3-week drug, which has the advantages of pembrolizumab without requiring biomarker testing, which has the advantage of nivolumab. And so either if you don't have a result or if that result is negative, This does demedicalize the life of the patient a little bit by giving an every 3-week instead of an every 2-week treatment. And I think that matters to patients to a much greater extent than we sometimes recognize as practitioners.
Yeah, and I think that I thought one of the impressive things on the OAK trial was, admittedly with the SP142 as the biomarker, that the hazard ratio for OS in the biomarker positive versus negative was identical. So, hence the no need for at least using that particular biomarker.
There was no clinical or biologic way to say that docetaxel won in this trial. Every way they cut it, atezolizumab came out on top.
Yeah, exactly. And so that's an important, so now we have 3. Does in the second line setting where we have 3 that are agnostic to histology, does histology make a difference in any of your thinking about which one to use?
No.
No? Does PD-L1 testing in the second line setting make any difference?
Well, Pembro's only approved.
No, I
positive.
understand. And obviously the backdrop today is that everyone's going to be tested first line, so you're going to know it's second line.
Right.
And is that going to make a difference?
Yeah, I'm going to probably give Pembro if I know they have some PD-L1 positivity, just for some ability to keep things the same. I mean, I already talked this up when I was testing them for PD-L1 in the first place, so now they
You got to be
get
consistent.
it. But don't worry if it's negative, because then you're going to get the other 3-week drug, atezolizumab.
Yeah.
When you saw what happened in melanoma, and again, this is to the convenience standpoint, and that's the only reason why I really liked docetaxel before was because of the Q3 week, and that's mostly in first line combinations, but there was a tendency to give the one that was less frequent, and so Pembro was the sort of drug of choice in melanoma because of the Q2 week versus Q3 week, Nivo being Q2 week. And then what changed was, again, the doublet. So then you got Ipi-Nivo, so now that became more popular because of that fact. I even, all things being considered, and again, PD-L1 positivity has to occur with Pembro, if the 3 of them were equal without any testing, I would probably lean toward Pembro just because of the schedule.
Do things like flat dosing, single vial, make a difference to you guys?
I don't think they make a clinical difference. I think they make a difference from a pharmacy standpoint. There's less wastage. It's easier to order.
But for us, we order on a computer anyway.
Was it a step forward in the movement to flat dose nivolumab?
I mean, not for us. We did try to figure out what would be the effect of the cost. Are more people going to move up or move down? And it seems like it's mostly a wash on that too. And that was true when we actually costed out the 3 drugs compared to each other as well. That they all roughly came out to the same. So there's no clear winner from that standpoint.
Yeah,
either.
and then I know at World Lung we saw some. There's now the 4th and 5th in line for the second, third line space durvalumab with activity that looks very similar to the other ones, and others coming. I mean, how many do we need?
Yeah, I don't see any clear distinctions between them.
And does anyone know? I haven't heard. I'll ask this question. Anyone out there making a biosimilar?
Oh, I don't know the answer to that.
I haven't heard of biosimilars yet for immunotherapy drugs.
Too early, right?
Yeah, I think
still
there has
on
to be some
patent.
time.
Yeah, I guess. I don't know what. I actually don't know the.
It's some number of years. I couldn't tell you the number, but we're not close to it.
Okay.
It'll be many years.